you all here today. We're first going to have our president and CEO, Cliff Douglas, come up and give a few words. And then we're really excited for the panel discussion we will have afterward with an opportunity for audience Q&A. So thank you for being in the room with us. Thank you for being with us on Zoom. We really appreciate it. Without further ado, I'd love to introduce Cliff.
Thanks, Catherine. I told Catherine she could say some more, very well-written, inspirational words, but she knew I was threatening to go long, so she was giving her time back to me. First of all, this is amazing. Thank you all for coming. What a special moment. I've been preparing for 36 years to stand here today and have a conversation. Let me start first of all by thanking our board of directors. I'm not going to name everyone for lack of time. Also our entire team stationed in several countries for your leadership, your support, your inspiration, expertise, especially your humaneness, not to mention the great stamina you all demonstrate every day in our shared cause. So good afternoon, everyone. I'm Cliff Douglas, and I'm here to announce that I no longer serve as the president and CEO of the Foundation for a Smoke-Free World. Since joining the organization last October, I've told folks that change was coming. So now I'm proud to share some news about our progress. As of today, we are global action to end smoking, as you can see. And in fact, as I think the news was breaking this morning. And we think it's the name that best represents the top line goal of our charitable mission, which is to end combustible tobacco use. That is the use of cigarettes and other products that are burned and from which the user inhales toxic, cancer-causing smoke. And those are the products that are, and I can't emphasize this enough, responsible for 98 or maybe even 99% of all so-called tobacco-related deaths. As many of you in this room and who are tuning in from afar are well aware, smoking kills a devastating 8 million people worldwide every single year and remains the leading preventable cause of death. And tragically, this toll is expected to rise, not recede. And so we've developed new approaches to strengthening the life-saving work of this organization in collaboration with others who are similarly committed. As global action, we're going to maintain our focus on funding cutting-edge health and science research. But today we're also embarking on a new area of commitment under the umbrella of cessation education. Unlike some other programs that employ similar names, though, this will involve addressing the widespread misinformation and sometimes disinformation regarding nicotine and relative risk that continues to both confuse and mislead millions of people who smoke, their healthcare providers, and many decision makers. And we're going to be promoting research and related educational efforts to accurately inform people about what the FDA itself refers to as the continuum of risk among different tobacco and nicotine products, and to objectively and compassionately inform people about the wide array of options available to support them on their distinctive, often distinctive personal quitting journeys. So, as I've been saying lately, we're going to step down from the ivory tower and meet people where they are, where they live based on their lived experience, knowing that one size doesn't fit all, and millions of people who smoke and the healthcare professionals who take care of them need to know this. So on that note, I'm delighted to announce our first new grant in this program of work, a significant research grant to the Urban Institute, the respected Washington, D.C. based think tank that conducts economic and social policy research to, as they say, open minds, shape decisions, and offer solutions. And with our support, the Urban Institute is going to examine Medicaid data in the United States to track the prevalence of claims for tobacco treatment, and they're going to seek to better estimate the number of low-income individuals living with tobacco use disorder and nicotine dependence. And crucially, they're going to work on identifying potential cessation barriers and then help us inform the development of solutions to those barriers. So it's pretty straightforward: public health, tobacco control, research, and seeking to figure out ways to accelerate our progress. In the course of my nearly 4 decades fighting the smoking epidemic, it became clear to me that one of our biggest challenges has been identifying knowledge gaps in the field so we can take corrective action. One of the most basic but destructive misconceptions we run into is the impression many people have that we have solved this epidemic, which results in part, if not in large part, from the fact that those with more years of education and with higher incomes, higher SES, in other words, those with more power and influence living in a certain stratum of society, don't see much smoking around them. So I'll be saying more about this in a minute. The US has seen tremendous success in its public health campaigns to end smoking. Smoking rates have fallen from an extraordinary 42% in 1965, that was the year after the first Surgeon General's report on smoking, down to 11% today. And that's a public health success that really is unparalleled in modern times, and it saved millions of lives that otherwise would have been lost due to more quitting and also less starting. The 2014 Surgeon General's report, that was the 50th anniversary report, found that in the 5 decades since the first report in 1964, 8 million lives had been saved or tobacco deaths averted by the increased number of people who had quit and young people who didn't start. But then, of course, we all know that this story involves a deadly paradox, which is that during that same period of 8 million lives saved, we lost more than 20 million Americans, so just speaking, domestically in this country, to smoking. And moreover, our success in reducing overall smoking prevalence has not applied equally across different segments of society. Many people who smoke today come from more marginalized, less advantaged communities. While I was leading the annual Great American Smokeout at the American Cancer Society, we dubbed what I'm describing the hidden epidemic, which we detailed in our 2018 study titled "Who's Still Smoking? Disparities in Adult Cigarette Smoking Prevalence in the United States." And we found that, and I just want to quote this passage: "The continuing high prevalence of cigarette smoking among specific subpopulations, many of them vulnerable, is one of the most pressing challenges facing the tobacco control community. These populations include individuals in lower education and/or socioeconomic groups, from certain racial and ethnic groups, and I would note in this country, above all, American Indians, in the lesbian, gay, bisexual, and transgender communities, with mental illness, and I would add with substance use disorders, and in the military, particularly among those in the lowest pay grades. And although traditional tobacco control measures are having positive health effects for most groups, we concluded the effects are not sufficient for others." So I'll say parenthetically here, it's all about social justice, about correcting those health inequities. So we've concluded that more attention to and support for promising novel interventions, in addition to new attempts at reaching these populations through conventional interventions that have proven to be effective, are crucial going forward to find new ways to address these disparities. So, in short, the individuals who continue to smoke have been left behind in the fight for health equity, and the status quo is not acceptable. The status quo is not acceptable. To address their needs, we have to first understand what's going on, and we have to meet them where they are. And that is one of the major reasons why I'm so excited to support the Urban Institute's new research, and they're here with us today. And this is just the beginning of our commitment to this type of action. Now, we're going to be focusing quite a bit, as I noted, on the challenges of misinformation and disinformation about nicotine and about relative risk among the many products across the continuum of risk, because this is a global problem that is halting our progress. And the groundbreaking work that my organization supported last year looked at 15,000 doctors in 11 countries and found that 2/3 of them mistakenly believe that nicotine causes the death and disease associated with smoking. And that is flat wrong, folks. It isn't true. The science is absolutely clear. So we're going to be in the business now of trying to set the the record straight using objective, credible scientific evidence. The nicotine that causes a dependency and is what drives the repeated exposure to 7,300 chemicals, 70 carcinogens produced when a conventional cigarette is burned, and which leads to the global health toll. But when separated from the dirty needle of the cigarette, as Mitch Zeller has correctly called it, nicotine is in some cases approved as safe and effective for use as a smoking cessation medication. So when you think about it, all of those people out there who smoke and might otherwise even just use nicotine gum or patch are not doing so because they're afraid that the nicotine is going to hurt them. So it has a direct impact even on traditional tools for smoking cessation. So we're going to be addressing that, and I would just submit that given that there are many individuals who either can't or won't quit smoking using smoking cessation medications, I would submit that it's a moral imperative that they not be forced to choose between those limited, too often ineffective options, such as the medicinal products, though we support their use, or nothing at all. That's not a good calculation to be pursuing public health goals on the basis of. So with so many lives on the line, we're stepping up our game, and we've crafted new resources and information for consumers, for regular people who want to learn how they can most effectively quit smoking based on the best evidence. And in some cases, depending on the lived experience and needs of the given individual, to help them move down the continuum of risk on their journey to completely quitting smoking, which is, as most people know here, responsible for the death of 1 out of 2 long-term users. Quitting is an urgent public health need immediately, right now. So we're going to be encouraging people to take the healthiest step possible, doing our best to respectfully meet them where they are. And I do believe, and I just want to say this clearly, it's been said before by others, that urging them to either quit or die is inhumane and it's unacceptable. So we're going to try to take a more sensible approach to giving people accurate information and providing the tools that can assist them in making the best health decisions for themselves and for their families. So let me just wrap up by emphasizing that choosing to take this journey with global action, for me, is the next logical step in my career, is what I hope I am, which is a forward-thinking public health advocate. And as we move forward with our efforts, we're going to take every possible step to ensure transparency. You know, public distrust of the industry is clearly warranted, given the industry's history of fraud, conspiracy, and concealment. It's why I've spent years as an attorney in the cases that resulted in the Master Settlement Agreement, the historic Engel class action lawsuit in Florida, the successful Williams case, went up to the Supreme Court 3 times before we succeeded, against Philip Morris out of Portland, Oregon, and the successful defense of the nation of Uruguay's groundbreaking tobacco control laws in the international trade action brought against that country by Philip Morris International. And it's also why I helped whistleblowers courageously come forward and testify in support of the FDA, Congress, the US Department of Justice, and private litigants against the cigarette companies. So last October, our organization terminated its prior agreement with PMI, and having made a final payment, the company walked away, eliminating any connection. This separation was essential to my decision to take on this unique role with what is now Global Action. And I then worked with our independent board of directors to adopt a formal new policy that this organization will not accept any further funding from manufacturers of tobacco or even non-medicinal, as in an e-cigarette, even non-medicinal nicotine products. So these announcements today, our name change, the strategic use of our resources, our effort to speak honestly, plainly, and accurately to the public and to healthcare practitioners, and our new commitment as part of all of that to the Urban Institute are the first of many that I look forward to sharing in the coming months. I'm optimistic about making smoking history. I want to thank everyone who's come here today and those who are tuning in for joining us on our mission ahead to end smoking and save lives.
Thank you so much, everybody. It is my privilege to introduce our panel discussion, where we will have Dr. Leighton Ku, the Director of the Center of Health Policy Research at the Milken Institute of Public Health at George Washington, excuse me for the non-locals, George Washington University, as well as Dr. Anthony Salandy, the Senior Director of Development and Business Strategy at the National Harm Reduction Coalition. This conversation will be moderated by none other than Kenneth Moton, a journalist with more than 2 decades of broadcast experience, who currently serves as co-anchor of DC's own Fox 5 News. Please join us on stage, folks.
Good afternoon. Good afternoon. How you guys doing? I'm not even sure I need this because I'm loud enough, but it's good to see you guys. Thank you again. And it is a new day for the global action to end smoking. How about that? The changes. When he said breaking news, I was like, my ears perked up because you guys know I love a little bit of breaking news here. So thank you guys again for being here. And it's good to see you. And thank you for this organization for having me here to moderate this very important panel. Yeah, all the smart people on this side and just the guy asking the questions on this side. I'm used to asking questions as a journalist, again, with 20 years of experience, which is, I know I look real young, but I've covered so many stories, good, bad, the ugly. And I always feel like I remember cancer-related stories where communities have come together to help someone who was in need. And then when you read the stats on smoking, the correlation to cancer, I think about that for my own story and how I've covered things in this news industry. I'm going to ask some questions to these very smart gentlemen over here, and then we're going to have a little Q&A as well, a chance for those who are watching us on the live stream. Hello to everyone out there who are watching us right now, and then for the people here in this room, if you have any other questions, we are happy to take those questions as well. So we're going to try to get a lot in here in this next 45 minutes. This is a discussion, and the thing I love about this as well, Cliff, and I think you mentioned this, is, and it's in your name now, action. We're having a discussion, but it's also about the action here, and that's what we're going to take, action. So let's start with the global state of play. Dr. Ku, I'm going to address this one to you, which is, Cliff touched on it, but what is the global state of play as far as a tobacco epidemic that people believe is over? Who do you see smoking these days? Well, there are a lot of people, millions in fact, who are smoking.
I'm not particularly a global expert. I'm focused mostly on domestic issues, but I mean, certainly we know, based on the information both here in the U.S. as well as abroad, there are, as Cliff has said, tens of millions of people who smoke across the U.S. In the U.S., we've been fortunate that we have seen reductions in smoking rates, really substantial over the decades. On the other hand, it still remains the case that, for example, low-income people, I'm particularly focused on the Medicaid population, are more than twice as likely to smoke as the general public. The situation is similar in so many other countries where smoking is in many cases at much higher rates because it is more popular in the U.S. There haven't been the cultural and other social influences in doing it, but it still tends to be something that is related to a great extent to class and to marginalized populations.
And Cliff, on the global aspect, what are successes, failures that we should be learning from?
Sure, Kenneth. We've got a lot of examples in all directions. We've got some parallels globally to what we experience in the United States, which is we have different populations having very different experiences, facing very different health risks, doing better, doing worse. We have countries such as the United Kingdom, New Zealand, which are taking very public health beneficial, progressive action to try to take a good scientific look at the true nature of the tobacco and nicotine marketplace to help drive down smoking in every way possible. And they've been doing it in ways that we have not really been doing very much of yet in the United States. New Zealand also, it has been taking similar action to incorporate, for example, harm minimization through the use of alternative products as needed for those who are going to benefit from them, and blended them with really cracking down on marketing that might appeal to children, to to continue to advocate the use of products that are regulated as medicinal products that also help people quit smoking. So in other words, taking a holistic approach, which is what we're now seeking to do. So those are the different kind of experiences going on worldwide. But what we do know is particularly in low and middle income countries, you're talking about 80% of the world's smoking population. So think about where the harm is most taking place. We can think about social justice from our more local and domestic perspective, but there's a worldwide urgent need to apply a social justice lens to help those folks who are most in need.
And Dr. Salandy, what other factors play a part in these smoking rates that we're seeing that could present challenges or opportunities here?
Well, if you take, thanks for the question. If you take a look at the risk groups in the United States, you talk about Black men, low-income populations, populations or groups that have mental health diagnoses, substance use, as was mentioned earlier by Cliff, people in rural communities. You see higher populations of individuals smoking in the South and the Midwest. And so these, it's not well understood, the predictors, the predictive factors of, why you end up smoking, especially if you come from those groups. But what we do know is that if you are in two or more of those groups, it increases the risk of tobacco-related poor health outcomes. So there's more work that needs to be done to really understand the predictors and and how do they interact, like the syndemic nature of those predictors on health outcomes.
Well, let's move on to harm reduction. This is a term that I have learned a little bit more about. Cliff has schooled me on it as well. Is it the phrase that we can say that we're allowed to say, harm reduction? I know it comes with multifaceted here, but can you give us an overview, Dr. Salandy, of the overview of the concept of harm reduction here?
Yeah, so harm reduction is a practical and transformative approach that incorporates a community-driven public health strategies like prevention, health promotion, risk reduction, and it empowers people who use drugs and their families to live healthier lives, right?
Is it misunderstood?
Is harm reduction misunderstood? Absolutely. There's a lot of misinformation about what harm reduction is. The harm reduction, the traditional sense of harm reduction came out of in the early 80s when HIV/AIDS, started, and there was a realization that intravenous drug use, unclean needles and syringes, and other drug wares was the source of transmission. But harm reduction sort of predates that. Even in New York City, where you had Black communities having mutual aid, right, to address some of the, what I'll say, health disparities in the community, and not just health disparities, but economic disparities in those communities. But let's fast forward to the 90s when harm reduction coalition started in Oakland. And you had a group of people who around the country started saying, hey, we need to gather syringes, clean syringes and needles, and give them out to communities that need them. And fast forward to today with Narcan and naloxone, those things are widely available. Although we need more, but they're widely available to individuals who are at risk for overdose.
Dr. Ku, when it comes to cessation.
And
Oh, sure, go ahead.
Just
Please,
let
go
me
ahead.
make an additional comment.
Of course.
Harm reduction is misunderstood. And I think that harm reduction is a social justice movement first and foremost. Harm reduction realizes that to address overdose in the United States, right, you must also address other disparities, unemployment, housing, access to, lack of access to proper medical care, right? So those are the things that, in addition to providing clean needles and syringes, we also take a social justice approach and saying how these are things that needs to be addressed as well.
Dr. Ku, I see you nodding on that. I mean, the man who has dedicated his life to public health here, and we know how extremely important it is, especially to marginalized communities. How do you even begin to start peeling back what needs to be taken care of?
Sure. So we've made, in the US, we've made a great start. I mean, we have some policies that we know that are very effective in having reducing, particularly the introduction of smoking. So things like cigarette taxes, regulation of indoor smoking have been pretty effective. Under the Affordable Care Act, now basically everyone who has health insurance in the US has access to tobacco cessation medications and treatment. On the other hand, we could do more. And so, you know, I've been involved in efforts working with CDC and with state public health and Medicaid agencies to try to see, can we make some further inroads? And I'll be honest and say it's been slow going. And part of it, I suspect, is that in the end, we all know smoking cessation, like so many other addictions, is tough. And there are limits of therapies. I mean, one of the things I guess I'd hope that maybe people can begin to consider, could we expand that armamentarium? Could we consider other methods of harm reduction? Things like, is it possible to consider the use of e-cigarettes as a safer alternative for smoking cessation? I understand, of course, there's the risk. You don't want to have vaping, which can increase rates of overall, smoking, and people worry about it as a gateway to smoking. But I think it's worth thinking, are there some new alternatives that might be done, perhaps as demonstration projects that help sort of engage a broader array of methods to help reach the multiplicity of types of issues and problems that people face. I'll mention the other issue, and I have to say this as a Medicaid advocate, that comes up in the issue of social inequality, is so if you have Medicaid, you have access to tobacco cessation. On the other hand, there are still 10 states in the US that have not expanded Medicaid. So in that regard, in my home state of Texas, if you make more than $6,000 or $7,000 a year, you're too rich to get Medicaid. So therefore, you can't get access to tobacco cessation treatments that you could. Whereas if you're in DC, here the income eligibility range is far higher, or across the country it's far higher. So there are still a number of states where even to get sort of access to some of those other things, there's social things that create and policy things that have kept barriers up that also could be eliminated.
So if policy is something that takes time to enact, to really have an impact on people's lives, then what tools, for those watching, for those in this room, what tools can you say, these are the tools to help you? People try to make it seem very black and white. And I won't say guilty with the news. We'll say, here's some tips to help you, but we all know it's not that black and white.
Well, there are some policy things that can happen. So on the simple things like Medicaid expansion, North Carolina, which we traditionally think of as a tobacco state, just recently decided to expand its Medicaid program. So there's a big success. So policies can change. At the individual level, part of it is sort of the recognition and the commitment to try to stop smoking. But on the other hand, we know that most people who smoke, or at least in the US, say that they want to quit. The problem is that there are any number of barriers that make it difficult. They've tried to stop in the past and have run into issues. So part of it is continuing that motivation, continuing support, whether it comes from their family, from their doctor's office, or potentially from other mechanisms of ways that we can try to provide further support. Some of it is further communication, but there's so much more that needs to be done.
Cliff, we've talked about misinformation, disinformation. What are the most common misconceptions about tobacco use and those who use it?
Sure. When it comes to people's understanding of what's driving this unique leading epidemic globally, there's a general conception that has spread widely, particularly even more so in the last even 3 to 4 years, that all tobacco and nicotine products are, for all intents and purposes, created equal. There's been a conflation of what people just generally refer to as tobacco products. And when you think about the actual marketplace, that continuum of risk, you're looking at products ranging from cigarettes on the far one end, which cause the death of 1 out of 2 long-term users, produce 7,300 chemicals, 70 carcinogens, those substances that cause cancer in humans. All the way on the other end is nicotine gum, nicotine patch, nicotine replacement therapies, which are regulated in this country and in some other countries similarly as safe and effective. And then in between, particularly depending on whether the products are burned and smoke is inhaled or whether they're not, they're all across the spectrum. And so the conflation that plagues a lot of people's understanding has been a very destructive force in terms of the public health impact that it has, because so many people, as a result, basically don't act in their own self-interest or that of their families, their kids, their brothers and sisters, their mothers and grandparents, coworkers, because they think that, for example, Zyn, which has gotten a lot of attention of late, a nicotine pouch, which in fact scientifically is pretty much very similar to a nicotine gum, is being regarded as this gigantic health threat. What's that going to do to the guidance that folks receive from their physicians or other healthcare professionals and what they decide to do themselves? Well, it's really going to skew human behavior, and it's going to skew very badly the public health outcome.
Thank you. Dr. Salandy, opioid epidemic, something that I've covered for years, and the impacts on communities. It's something when it comes to opioid epidemic, I feel like mainstream wise, we're seeing movies about it. We're seeing settlements, massive settlements. It's in the headlines more and more. So are there things that we could learn from here when we're talking about smoking cessation when it comes to the opioid epidemic?
Well, that's a piece of misinformation as well. There's no opioid epidemic in this country. There's an overdose epidemic in this country. It's a national health emergency. And so when we frame it like that, when we think about what's the action that we need to do, we need to decrease or take steps to decrease the overdose incidence rate. Right, so that's one thing, and I think harm reduction is an approach that can decrease and really has been shown in research to decrease overdose rates throughout this country. Two, SAMHSA like last month or 2 months ago put out a harm reduction framework that really outlines the pillars, the principles, and the practices that this country needs to take in order to lower the overdose rate. Similarly, HHS came out in March with a framework to support and accelerate smoking cessation. If you map those two documents together, they are very similar, right, in approaches to decreasing quote unquote addiction to a substance, right? I think that the SAMHSA harm reduction framework can inform HHS approach to smoking cessation. And I think that needs to be considered throughout all of the centers at HHS, which SAMHSA happens to be one of them. But I think the important part to understand about where does harm reduction fit into smoking cessation is that harm reduction talks about low barrier to treatment, right? Self-directed care, right? Autonomy, right? For the individual, compassion, support, community engagement, right? All of those things are really important if you're going to get at decreasing smoking in this country.
So you guys touched on it when it came to vapes. There's all ways that people can, smoke these days. So when does that come into the conversation about vaping? I know when I was growing up, there was a lot of talk about nicotine gum and nicotine patches to help stop, but using other things to stop using tobacco.
Yeah. Well, first of all, when I was growing up, we were waiting for the invention of computers. Still writing on stone, Kenneth. The onset or the introduction of vaping products, and then a number of other alternative, what we just generally refer to as alternative nicotine products in our society, starting particularly in the mid-2000s and beyond, has really transformed the landscape. As part of which we consider what might best work for public health purposes and if you will, private health purposes, the decisions that individuals need to make in their own lives to reduce their chance of illness and early death. And what we found is that the science has increased fairly substantially and quickly in recent years, showing that vaping products, for example, and I'm talking about nicotine vaping products, generally called by that catch-all term e-cigarettes, are found to be more effective in many cases than nicotine gum, than the nicotine patch, in enabling people to stop smoking. The Cochrane reviews out of Oxford in England have increasingly found that the evidence is getting stronger about that fact. And so that's something to look at when we decide what's going to work best for public health practice and particularly for medical practice as well. Now, the other products that have been emerging on the marketplace, they can be nicotine lozenges, nicotine pouches. There are the heated tobacco products. They don't burn, such as IQOS, which the Food and Drug Administration has actually reviewed and authorized as a product that produces fewer harmful chemicals. These are all ways that people can be informed about and consider as they try to figure out, how am I going to save my life? Because we know that 1,200 or 1,300 people are dying every single day in the United States from cigarettes. Think about anything else even remotely comparing to that, and you won't find anything, except maybe at the very peak of COVID for a year or two. And otherwise, it's a uniquely lethal process. And so we're trying again to bring compassion and sensitivity to people's lived experiences here, to figure out what they need to know and what they can do to act on that in their best interest.
Dr. Ku, can people afford these tools, these items, some of the things that Cliff mentioned?
Well, it depends. Once again, if you're a well-to-do middle-class person or upper-income person, yes, you can afford these alternatives. And again, certain alternatives, again, tobacco cessation medications and therapy are available to everyone who has insurance. But if you're lower income, if you're uninsured, then you have problems. So certainly there is a cost associated with vaping. On the other hand, I will note that in general, vaping is probably less expensive than buying cigarettes. So, I mean, that's to me part of the harm that occurs with the marginalized fact that, sort of low income people in the US have such high rates of smoking. It's darned expensive. So if there are ways that you can provide relief from that not only helps people improve their health, save lives, and maybe saves them some money so that they have a little more to do. They can help pay for their rent, for their food, for education and other goods, then that's altogether a win. There are certain controversies that exist in this area, so I won't say that it's completely straightforward, but I think that there are things that we could do in trying to expand that sort of range of options that are sort of more sensitive to the various experiences. And I hope that we can do some of these things. But again, right now, there are barriers to things. And certainly in the e-cigarette vaping area, part of the problem is there's so many different ways in which it's done. Some of them are pretty expensive, but there are some that are less expensive. So that's also part of it, is that is still a sort of confusing range. It's not as though it's a simple thing that there's like buying a pack of cigarettes. Though it's expensive, there's a fairly simple thing that you can do. Vaping is more complicated.
Sure, Dr. Salandy.
My perspective, stigma is the greatest killer of all. I mean, it's smoking cigarettes is not a moral failure. It's not a character failure, right? And providers, mental health providers, medical providers, counselors need to understand that. And the more we educate them around misinformation, but we educate them and try to get them to take the other perspective. And some of them, it's very difficult to do that if you don't have that lived experience, right? If you don't have that lived experience or living experience, it's very difficult. And so in harm reduction, we center people with lived experience to go into the communities and find out what people need. What are their needs? What are their strengths? in the community? And how can we activate that strength so it would empower the community? And I think that how some of those, and again, some of those approaches that are used in harm reduction are going to be important in this effort in terms of smoking cessation.
But getting to the root of this, how it's viewed, this stigma, I'm just curious, something you said just sparked in my head about, is it safe to say that every person on this globe has had some type of impact with smoking, whether they are a smoker, they know someone who has smoked, they've been at a restaurant where someone is smoking and didn't like it and found it to be annoying. There has been something in their lives that there's been some cross section. So is the stigma that you're talking about, how is that having an impact on policies, on how we treat it, how you say people need to think on the other side of this from the other perspective here? If everyone's had this, you mentioned like they haven't had that, that lived experience, but I think everybody can come have at the top of mind a smoking story and how it's impacted them.
Well, having lived experience in smoking combustible tobacco, I was in the military back in '83, and I smoked my first cigarette in the military. The reason why, I was given a half a pack. And not just me, everyone in the platoon was given a half a pack of Cools, menthol cigarettes, right? And in addition to the smoke break that we would be given, right, where people would go and smoke, right? And I'm not, that probably doesn't happen now. But I'm going back to the stigma and your question about what happens when someone is stigmatized, their behavior is stigmatized. For a medical professional, for a person that's stigmatized, if you have someone that's using drug that goes into the emergency room and a doctor or a nurse looks at them a certain way, seats them away from the general population, says something or uses something like the word addict, or, these are terms that turn people off, right? And the farther away when you turn people off, the farther they get from treatment, right? And so you want to be able to use language that engages individuals, language that engage the individual, and so they can seek help, self-directed help, right? But once you stigmatize and you use stigmatizing language, you push people away. And that's what education of medical primary care providers is extremely important. And not just CEU credits, right? This is continual professional development, because medical providers will face situations that will challenge their perspective, or should face situations that challenges their perspective. And then they should be able to turn to educational resources that can help them navigate those challenges.
I understand. Thank you for that. I appreciate it. Cliff, in our final seconds here before we get to the Q&A, that one piece of advice for someone who's watching, who's trying to stop smoking. I know it seems a simple question, but it doesn't have a simple answer.
Sure. Well, perhaps just slightly self-servingly on behalf of our new, reestablished organization, the resources that we're making available. If one were to turn to our new glowingly appealing website, you will find an excellent array of honest, objective, and holistic resources, communication about the science underlying them, what will work or not work for certain people based on their circumstances. And that's something that you're not generally finding in most places. You tend to find things kind of segmented, kind of exclusively produced, so that they're not giving you all of the information. We're trying to do that. That's a message that I hope has come through pretty loud and clear today. So, I would say, obviously communicate with that healthcare practitioner who you really trust, and hopefully they will be fully educated, or like some patients do today, you educate your doctor, or, come to a resource like ours, and we will try to simply supportively provide the information you need. There are many different ways to quit smoking. The main thing is, and that's why it is our by far top line goal, is to try your best to do it. And we've got experts in the room here. I'll look at Mike Cummings over there, who not only engages at the high level ivory tower policy level, but also is an expert in the direct delivery to real people and has worked with thousands of them. And if he chooses in a question or comment to share a little bit of insight into that, that would also be welcome. But I think that's very achievable.
I love it. We're going to move to the Q&A. Thank you for this. I know you guys still have, thank you. We're not done yet. We are taking questions from our live stream. So if anyone out there would like to ask a question, please reach out. You see the information about how to ask a question there online. For in the room here, I saw this gentleman here, and I'll get to you, sir. You wouldn't right here, this gentleman on the second row.
Oh, second row.
To pick up on what you were saying, and a question for any of you really, what do you think needs to happen for tobacco harm reduction to become more squarely integrated within the broader harm reduction movement, both on a messaging level and a practical level, given that a lot of harm reduction organizations haven't traditionally seen smoking among their top priorities, and given the existence of certain major funders of US harm reduction organizations that actually seek to restrict availability of products that help people quit smoking?
Well, it's a great question, Will, because as we know, I'll sometimes joke darkly that THR, for tobacco harm reduction, has become a four-letter word. And tobacco harm reduction, which, I tend to steer away from, it's kind of a catch-all. It's not the greatest terminology. I also tend to lean toward, because it's my own preference, if you will, harm minimization, because reduction can be mild, it can be slight, I suppose, conceptually, but we want to ensure that whatever we do will help people really drive down their risk of illness and death as much as possible within, again, with reference to their needs and preferences. I do think that since so-called tobacco harm reduction has become kind of the poor stepchild in the larger arena of harm reduction, that it's really important to normalize it now as part of the larger concept of harm reduction. And having Dr. Anthony Salandy here, I think it is really a significant moment that I hope people recognize, because he is here representing the Harm Reduction Coalition, which, if I'm not mistaken, has really not spent time focusing on reducing harm from tobacco products or from smoking previously, but are recognizing the true fact-based value of incorporating it in the larger concept and efforts in public health and in practice to reduce harm across the population. And when you think about it, I know that, Dr. Salandy gave some examples. If you think about it, seat belts and airbags in cars are forms of harm reduction. You have not taken this 2-ton contraption and made it safe by any means. It still involves the death of a lot of people. But if you've incorporated those harm reduction devices, you're going to save a lot of lives and reduce injury. And that's what's taken place, because we know that people aren't going to just stop driving their cars. Well, we have 30 million people using cigarettes in this country and 1.3 billion people using tobacco products worldwide. They're not going to stop doing this tomorrow. How can we do our utmost to incorporate this area into the broader harm reduction arena to hopefully then save the most lives through action?
Ron Bullen from Australia. I just wanted to comment on the where we should go in smoking cessation. I think we should be looking at what smokers are actually doing, or people who used to be smokers. From the early introduction of vapes, smokers have come in some countries to be the predominant means of quitting smoking. In the UK, that's the case. Even in Australia, where they're all banned effectively, about 20%, some percent of quit attempts use vapes, virtually all illegal vapes. So people are prepared to break the law to get these things because they actually work more effectively. But they only work more effectively if you continue to use them, because it is not a medical problem in the conventional sense. It is a behavioural choice. most smokers get benefit out of smoking. They also worry about the risks. They're now being offered something that has a lot less of the risks. We don't know exactly how little, but very little, and the opportunity to get many of the benefits. And that's an easy option for people to take. And people are taking it. They're not going to their doctors about it. The doctors, as somebody presented, are incredibly misinformed, even more misinformed than smokers on these issues. So we need to be talking to the smokers and looking at what they want. And it's clear that many of them want vapes and other such products.
Thank you. Dr. Salandy, your thoughts on?
To answer your question, I'm going to answer your question. You're absolutely right, right? Traditional harm reduction is not focused on smoking cessation, right? It's not something that the movement has typically done. However, individuals who do use substances do smoke, right? And we are looking at the total individual when we are doing our programming, harm reduction programming. And so part of that, my place on this panel is because I believe that harm reduction and smoking cessation can go hand in hand because it benefits the people that we serve, right? And then I'm not I'm not gonna. The only thing I'm gonna say about your question is that in harm reduction we center the individual, right, with lived and living experience, right, and we try to have them the autonomy, right, to make their health decisions, and we have to respect that, right, and the more providers understand that, is going to be important for moving smoking cessation forward.
Another question. You're on the second row in the back here. And reminder for viewers watching on Zoom, please use the Q&A function and ask your question there, and we'll be able to ask our panelists.
I'm Charles Gardner. I'm a private consultant and happy to be here. And Cliff, I want to congratulate you and the entire foundation team. I think I have great hopes for going ahead with the future global action to educate the public and to educate journalists. And there are some good journalists. There's Mark here, there's Kenneth. And to educate politicians is critically important. Now, the issue I want to raise here is that education comes from experts, it comes from researchers, but it can also come from people with lived experience. And you're already hearing this. And I'm sitting on either side of me are two prominent advocates in this space. There is a huge cadre of people out there all over the world who have self-organized into organizations, who have lived experience because they are ex-smokers who have quit, with the harm reduction that dare not speak its name. And they're constantly accused of working for big tobacco or big vape, whatever that is. And I hope you can find a way to harness their energy because they're all operating on a shoestring.
Yes, please. Yeah. Right, Kat. Oh, yeah, I'm sorry. Go right ahead. Go.
Thank you. I'm Robin Mermelstein, and I'm from the University of Illinois, Chicago. And I'm actually, you've made a great point because I was going to follow up with that. One of the principles of harm reduction is centering and engaging the community. And I think our failure has been not to engage smokers. Rather, they're stigmatized. And when we talk about community engagement, uniformly, that's community engagement against smokers, against smoking. And so we get very hierarchical, top-down approaches that further stigmatize smokers and put up more barriers, I think, to considering alternatives for what may be potential options to help and to engage. So I agree, we've done a really poor job of mobilizing people who were trying to help. And, I think about all these other advocacy organizations, think about cancer and cancer survivors and how that moved from, 60 years ago where nobody would say that they had cancer. They were afraid to ever acknowledge that, to now people wear it being a survivor or a point of pride and go on marches and advocate for money, for funding, for help. And I think that's part of, given that there are potentially more tools, we haven't engaged appropriately. And I think that's a tenet of harm reduction, that we've done community engagement, but in very anti-smoking ways.
Okay, and as can you also answer this question for me, piggybacking off that? Some of this seems to be PR related as well. Am I wrong to say that? And this is coming from the news guy, who, when it comes to public relations, we know how extremely important that is as well, and getting out the correct information. So, I feel like we haven't really touched on the public relations of it all, and making sure that people are using the right words, making sure not to stigmatize. What are the biggest no-nos and phrases to use? Because you corrected me on opioid epidemic.
Well, it's harm reduction. We like saying, right? Nothing about me if I'm not included, right? And I'm not getting it right, but basically, don't create interventions for me, right? If you don't consult me, if you don't ask me, if you don't allow me to help develop and implement those interventions. And so that's like one of the tenets of harm reduction.
And it's exactly what we have not done in
Exactly.
in a lot of our approaches.
Exactly. And one of the things that, in terms of research, one of the things that National Harm Reduction Coalition is doing is actually training individuals with lived experience to lead research, to drive research, right? And I think that's important. And to your point, the PR, I won't talk about the videos of police persons touching fentanyl and passing out and shaking, and then later on, they coming back and saying how that this, it was an act, right? To colored candies coming across the border with fentanyl, so because Mexico wants to kill our children. Those types of messages aren't good for our community. And the worst thing that it does, it deteriorates trust in our communities and news folks, right? In the media, right? It deteriorates that trust. And so it's harder to build back that trust, right? It takes more energy, it takes more money to go back to the communities and say, hey, I'm sincere now to do that. And you're absolutely right. Mobilizing people with lived experience is so important. And we need to put money into that. We talk about one of the tenets of harm reduction is mutual aid, right? And mutual aid is talking about helping people I'm helping you, you help me. It's not top down, right? It's very horizontal.
Cliff, are you winning the PR war though? I mean, is there a winning losing of the PR war? Because I'm still stuck on this whole, because we have a lot of people watching. There are a lot of people in the industry who are in this room, but a lot of people who are watching who are not as educated about this. And they're trying to learn not only just the basics and what the issue and the root of the problem here is, or how to help themselves, but if you're getting bombarded with images, or I'm thinking about how, as a news guy, I've covered Dulles International saying Customs Border Protection, and they confiscated, these drugs or a candy that has laced with whatever. And these are the images that are pouring in from government officials, but then that could also do harm and the messaging here and what the truth here is. And so PR wise, are you winning, you're losing?
Sure. I hesitate to just frame it as PR, but you're right. That's a component of it. I think in terms of broader information and education and the understanding or misunderstanding that flows from it. If we were winning that war, if you will, then 2/3 of physicians in the United States and all over the world would not believe that nicotine kills you. They would understand that it's all of the cancer-causing and toxic chemicals in the smoke produced when you burn the product. And yet, on that very simple, if you will, scientific fact, it's not understood, and it's not any better understood, not surprisingly, by your average member of the public, including people who smoke, the ones who are in most urgent need of good information so they can take action that will help them. So no, well, I guess to borrow from the subject matter at hand, we're getting our butts kicked. And the fact of the matter is that, we're interested within the context of funding good cutting edge research and then disseminating good information that will help people emerging from that research, as well as research produced by others, because they're good scientists. Some of them are in this room, many universities who are producing a lot of the information that we need and are looking for. We're going to disseminate it. We want to make sure to be able to synthesize it and give people the best information. And by the way, on a practical note, thinking about Dr. Mermelstein's comment, we're looking to look for new, good, cutting-edge opportunities within the parameters of our resources to support more research that is going to get at some of these issues, including the need to bring into the fold real people, the people with the lived experience who are using all of these products. And as we've just heard very, eloquently stated, need to be part of the puzzle here. They need to be able to contribute, and we do have folks in the room who can feed that as well. But, we would like your ideas. We would like actual proposals and to talk to you about what needs to be done and how we can make it happen.
Question here on the front row.
I'm Mark Gunther. I'm a reporter who writes about these issues. Cliff, as you know, probably better than anyone else, there's still a stigma attached to tobacco industry funding, although it's applied inconsistently. No one complains about Truth Initiative living off a tobacco industry grant. What efforts, I have a second part to the question, what efforts have you made? What success have you had in diversifying funding, perhaps from public health oriented foundations? And the second part, I don't know if this is related, but I have my suspicions. Scott Gottlieb and Mark McClellan were going to be here. They're not here. What happened?
Sure. Happy to answer these extremely fun questions. What? Yeah, you absolutely are, and you're doing your reportorial duty. So Mark, first of all, and I've stressed it and we've stressed it, literally from the first day that I had taken the reins in this position, we have taken multiple significant steps to ensure that the independence and strict separation of our organization is crystal clear to anyone, willing to consider it. And so we ended the prior agreement. We adopted the new policy whereby our organization will take no other funding going forward from any manufacturer of a tobacco or even a non-medicinal nicotine product. So I talked about Zyn and e-cigarettes, and IQOS not going to take funding from the makers of those products either. One might have mixed feelings about it, but we are not going to do it because we want to be sure that's clear. All of the efforts that we're taking to build partnership, to build collaboration, to support, for example, as we've been talking about today, the fine expert work of an entity like the Urban Institute is building to critical mass, where we're increasing the legitimacy, the credibility around all of these efforts, because that's the real world that we're in. I took this on, people have pointed out, as a risk at this stage of my career, as I near my 95th year as a human being. And, so why would you do that? Well, the fact is that we are getting steamrolled out there in the information environment. Some folks have referred to it, I think, pretty aptly as an infodemic. And we have some resources at our disposal to use strictly independently, based on the science, based with input from folks like the experts in this room and those who are tuning in, to do our very best to make progress. And I think that is all going to add up to a lot more ability to associate with an increasing number of partners, of collaborators, to diversify our funding and continue to move through this evolution in a very good and positive direction, which I'm thrilled we've been able to do to the extent we have within a short 7 months. Well, there is the former commissioners of the FDA. That was my next soapbox. No, but quite seriously, actually, a little inside baseball. Mark McClellan and Scott Gottlieb are interested particularly in focusing on FDA regulation and the ways in which we need to ensure that our agency in the United States much more effectively applies the appropriate for protection of public health standard, streamlines the process of the pre-market tobacco application review and authorization process, communicates to the public, and it's a very discrete area of focus. So we are looking forward to, in collaboration with them, doing something more going forward. We decided not to do that today, but to just move it down the road a little bit so then we can focus specifically on that. Because today, as we came to recognize, is a different kind of day. We're making some announcements, we're representing ourselves, and we're really talking about the global scene of the tobacco epidemic and how to address these issues, you know, in the context of low and middle income countries, talking about, as I noted, the United Kingdom and New Zealand and other examples, so that we're going to come back to the narrow domestic focus, and they are going to be front and center and probably leading that whole process. And they are happy to talk to reporters. We're looking forward to that. Okay, did I? Okay.
He'll be around after.
I don't even know when I'm being a politician. Seriously.
I want to say thank you again. We're going to leave it right there and leave it with Cliff. And we're going to be here. So obviously for those who are still in the room, there's time for even more questions if you would like to. And for those online, shoot us an email, send us a comment. We'd love to hear from you. Thank you again for this conversation. Thank you for having me. Thank you, guys. Thank you. Thank you all for being here.
Yeah, thank you, everybody. Fun. Please stay and mingle. We have food outside and beverages outside. Please continue the conversation out there. Thank you so much for being here, everybody.
Thanks, Yasmin. There we go.